Hello, my name is Dr. Robert Cole. I'm the Chief Medical Officer of Autogenomics, a molecular diagnostics firm in San Diego, California. Today we're going to talk about understanding Kras and BRAF testing in cancer. The majority of epithelial cancers are marked by a functional activation of growth factors and receptors of the epidermal growth factor receptor family, or EGFR. EGFR was the first growth factor receptor to be proposed as a target for cancer therapy. EGFR is a transmembrane receptor. The receptor site is present on the outer part of the cell. A number of different proteins can bind to the EGFR receptor. Changes in the receptor bring activation processes to bear in the cell. Tyrosine kinase activates receptor autophosphorylation. Two main signaling pathways are triggered by activation of the EGFR. The PDK1 and AKT cascade are involved in anti-apoptotics and pro-survival signals. The RAS, RAF, MAPK cascade, which controls gene transcription, cell cycle proliferation from G1 to S phase, and cell proliferation. If we look at the diagram, we see that the EGFR receptor is present in the membrane of the cell. When certain proteins bind to the EGFR receptor, the EGFR receptor then becomes a pair or dimer. This triggers a phosphorylation process which activates the two cycles. The area that we are most concerned about is the RAS cascade, which is designated on the right. The net effect of both of these cascades being activated is cell proliferation, cell survival, invasion and metastases, and tumor-induced neoangiogenesis. EGFR inhibitors are now available for clinical use. There are two classes of drugs in this category: the anti-EGFR monoclonal antibodies and the EGFR tyrosine kinase inhibitors. The anti-EGFR monoclonal antibodies work specifically to block receptor binding on the outer part of the cell. The EGFR tyrosine kinase inhibitors work within the EGFR receptor that is within the cell to block autophosphorylation, which then begins the activation of the cascades that we described before. These anti-EGFR medications are effective in the treatment of non-small cell lung cancer, colorectal cancer, squamous cell carcinoma of the head and neck, and pancreatic cancer. Unfortunately, only 10 to 30% of patients will have a clinical benefit from EGFR inhibitors, creating a need for identification of useful criteria for selecting patients for treatment. As we described before, the RAS element of the cascade, which begins the activation of the various signals which generate cancer in the cell, has a modification or a mutation which occurs, which is designated a Kras mutation. These mutations are present on codon 12, codon 13, and codon 61. When this mutation is present, activation of the RAS, RAF, MAPK, and PDK1 and AKT cascades occur independent of EGFR signals. That means that regardless of the status of the EGFR receptor, these two cascades are being activated because of this mutation. The mutation is present in approximately 45% of colorectal cancers. Patients with this mutation have a uniformly poor response to anti-EGFR medication. There has been much literature published regarding this, and the American Society of Clinical Oncology, as well as the National Comprehensive Cancer Network, both have strong positions that patients that are being considered for anti-EGFR medication must have their tumor cells evaluated for the Kras mutation. If the Kras mutation is present, these patients are not appropriate candidates for anti-EGFR medications and should be offered other chemotherapeutic alternatives for treatment of their metastatic disease. Recently, the FDA has also agreed that Kras mutation is appropriate prior to institution of therapy with anti-EGFR medications as well.